Okay, so just to refresh from yesterday, when we talk about equine anesthesia, there are two forms of anesthesia that we're typically talking about. So you're either going to do field anesthesia, which is typically, now you can do field anesthesia in a hospital, but it literally means TIVA. So you're not intubating, you're not doing a ventilator, and it's really procedures that are under an hour and a half. An hour is recommended, but if you think it's going to be under an hour and a half and it's not an advanced procedure, you can do TIVA, or they need to be in the hospital where they get kind of a combo induction, intubation, maintenance. Now, when you get equipment ready, it's very similar to when we talked about small animal. So you want to get everything set up before induction. So you set up your machine, you leak test it, endotracheal tubes, your catheter, get all your drugs, and when we anesthetize a horse, it's especially critical to have everything ready because we do what's called a bolus technique, where you give them all of the drugs. We don't do the titration like I talked about with propofol, where you give half and wait and half and wait. Um, in the horse, we want to make sure we get through that excitement phase. We don't want a horse going through stage 2. So you want to have everything ready because you have to give everything pretty quickly, one after the other, to make sure the horse falls asleep right away. So, getting everything set up, everything ready, making sure your circle system, which is your rebreathing system, is ready, the ventilator is tested. Now, warming equipment, there's not really a heating pad for an adult horse. I mean, they do make larger heating pads, but they don't really get cold. But if you're going to work with like a pony or a foal, we did have regular heating pads, bear huggers, all of the warming equipment, because the younger ones tend to get more cold. And at Purdue, we had what's called a foal unit. So we had a separate room because we would see a fair amount of sick foals, some that needed some advanced procedures. So usually if you're doing surgery on a foal, they can get like a hernia, they can get an injury, or they can just be a poor doer. So we had like a little intensive care unit at Purdue, which was the foal unit. And we had heating pads and blankets because, again, they can be pretty cold. But the big horses aren't really going to use heating pads and things like that. And then obviously the crash cart, having an emergency box. Now, I don't have it on this slide, but if you're going to do field anesthesia, and maybe you guys have seen, usually farm vets have those trucks that are kind of like a mobile hospital. So I do want you to know for the test, like if you were going out to a farm, what would you have with you? I mean, you would have, catheter stuff, drugs, surgery prep, maybe surgical instruments, a crash cart. You may have like a pulse oximeter. The things you're not going to have on a farm is you're probably not going to have a very large anesthesia monitor. So if you're going to monitor a horse in a field, stethoscope, and again, maybe one of those portable, like you guys used them in radiology, those little portable pulse oximeters. You can bring one of those out there, but you're not going to have and maybe on your truck, you may have a portable oxygen tank in case of an emergency, but you're not going to have like the full big H tank anesthesia machine, ventilator. So normally the drugs that we would use are going to be similar. So we do, now we tend to use acepromazine as a tranquilizer, but we don't, now in foals, you might use midazolam or, diazepam. But the problem is, if you remember, midazolam and diazepam are not sedative in nature unless they're extremely debilitated. So they're not going to be as useful for sedation. They're not potent. So typically acepromazine, xylazine is another alpha-2 agonist that's used. And then remember, xylazine is used more in large animal. And remember, xylazine comes as 2 concentrations. So xylazine has a small animal, 20 mg per mil. and has a large animal, 100 mg per mil. So it's more concentrated, so you can use a smaller amount. So you just have to make sure you have the right xylazine with you. Now, is there anything I need to worry about with opioids in horses?
Aren't they sensitive to it?
Yep. So horses are more sensitive to the pure opioid agonists like morphine, hydro, fentanyl. So we tend to use butorphanol a little bit more. Buprenex or buprenorphine would probably be too much, or it'd be a little expensive because you'd have to use such a large amount. So they can get them. We just have to adjust the dose, but horses and cats are just more sensitive. They tend to get more of the dysphoria. And again, I don't want to see 1,500 pounds of an animal that's dysphoric. You know, a cat flips out, I can throw it in a cage with a blanket. If a horse flips out, this is what so we're going to use potent sedatives to counteract hopefully any dysphoria. So the key, and this applies to cats as well, if you're going to use pure opioids in cats, because they are superior analgesics, you need to use a pretty potent sedative with them. And hopefully the sedative will counteract any morphine mania or any of that dysphoria. So whenever I use a pure agonist in a cat, and I have in certain cases, I give them a pretty decent dose of sedative to try and keep them calm. That's kind of how we do it. Now, anticholinergic drugs are not routinely used. This is atropine and glycopyrrolate, which again, you're giving them to either prevent salivation or to prevent bradycardia or to treat. The thing we worry about is anticholinergics. Remember, they slow down the GI tract. And I've already told you in horses, GI motility is key because they're hindgut fermenters. So we don't want to slow down their digestive system. Now, this means we don't use them routinely. If you have a horse having a cardiac emergency, atropine is a major CPR drug. You're going to go ahead and give it. I mean, when they're having an emergency, all bets are off. You're going to have to use atropine. This is just saying we don't use it routinely in every case as a, we don't use it routinely. And we do worry about the GI motility potentially resulting in colic. So we don't want to do that. Here are some different machine setups. So they're all different arrangements. And so I'm just pointing at, under 300 pounds, you can use a small animal machine. Now, for large animal machines, the Y piece here, the rebreathing system, is these long black tubes. It's a very thick corrugated plastic. Corrugated are those ridges. Whenever you have tubing that looks like it has those ridges, and all of the tubing at school is that corrugated tubing, it's corrugated to mix the gases. That's what the corrugated tubing means. So, and usually these stay, you can take them off, but they're very heavy. They usually stay on the machine. And here's that very large rebreathing bag. I want to say, in this picture, if it says, a 35 mil bag, but 15 liter and 30 liter bags are common bag sizes that we use in horses. So you can see how large the bag is. Letter B is pointing, that's the soda lime. So you have a soda lime canister. Obviously that's much bigger. And then letter D is the ventilator. And what you're looking at in that black, it almost looks like an accordion. And when you have an animal on a ventilator, it actually takes the place of the rebreathing bag. So there's a hose that you're going to hook up from the back of the ventilator to here, because when the ventilator squeezes, the ventilator is bagging the horse for you automatically. And then we put them on what's called continuous ventilation. And so these different ventilators, and that's the controls at the top. So, you know, there's the flow meter, and then they have the controls. And I will tell you, I would never expect a new grad to come out and throw this animal on a ventilator. I got trained, even when I was at Purdue, I knew what a ventilator was. And when I started working in anesthesia, I was then trained on how to use the ventilator. So that's kind of an advanced training technique. But all horses under general anesthesia are going to go directly on the ventilator. They're just going to be, because they do not breathe efficiently on their own. And it's very difficult to manually bag them like we do a dog and a cat. So they will be put on a ventilator. So as far as getting the horse ready, there is kind of a flow. Normally here the horse would have a pre-med. At Purdue, we had these prep rooms, like these, there was like a stall, and then we had a prep room, and then the OR was right next door. So the horse could literally go from the stall to the prep to the OR. It was all together. But they would be brought in, they'd be given a pre-med, IM, like maybe like ACE butorphanol or butorphanol and xylazine or something. They would be put in their stall to cool off, chill out. And then we would come out and put a catheter in the jugular vein. Now, if you had, I will give you an example. If you had a very sick colic, so you had a horse that was pretty ill, and maybe they were very lethargic, you might be able to put in the catheter with them awake. But in a healthier horse, a more awake horse, we usually want to give them some sedation for the catheter. So then they come in, we put in the catheter. The other thing is we need to wash out their mouths. So actually, what they're doing with this horse, you can see in the picture, is they have, this is called a dose syringe, and I'm trying to think how many mils this is. It has kind of a metal tip, and we had a bucket of water, so we just sucked up water. Well, actually, let me see if I can bring up the video, because it is easier to let's see. Okay, and I had it pulled up earlier. And here we go. It actually talks about waking up a horse safely, but it does show oh my goodness.
My name is Ron Monsa.
Sorry, I'm trying to get to my, here we go. And hopefully you guys can see this okay.
I'm the program director for the anesthesia division here at the University of Minnesota College of Veterinary Medicine. The process of anesthesia starts with placing a catheter.
And I'll try to pause this a few times to show you, but you can see, so this horse has probably had some sedation. You can see this is like attached, and then they put a little suture here, and then they have a large extension set. And they're actually giving some additional sedatives, probably some antibiotics right now ahead of time.
Jugular vein in the horse's neck. And then usually the next step is we'll give a small dose of a sedative to calm the horse down. We rinse the horse's mouth out with some water to remove any food material that they tend to have in their mouth, so that we don't put that into their airway once they're asleep. And then once that process is done, we walk them into the induction stall, put them behind a padded gate, and let them calm down and settle in there. And then we give a dose of a couple of different drugs called induction drugs, which are given fairly rapidly intravenously. The horse is then rendered unconscious and slumps to the ground. At that point, we place a endotracheal tube into their airway. So it goes through the larynx into the trachea. And we use that to administer inhalant anesthesia, which keeps the horse asleep throughout the anesthetic period. Once the endotrach tube is in place, then we hoist the horse with the hoist system, place them on the surgery table, attach our various monitoring devices so that we can start assessing the horse's condition.
Now, they don't show like the whole thing, so there's usually quite a team doing this. This isn't like two people. This is usually a big team because you have the surgery people are putting the hoists near the fetlock joint. It doesn't damage the horse to lift them if they put it in the right location. If you put it in that divot, which is kind of where the hoof, just proximal to the hoof where it indents, you put the bands, and then they're going to hoist. What they have in the horse here is a mouth gag, and they keep the mouth open for intubation. And now they're hooking up the piece here, and then you can see there's a very large bag of fluids. We use 5-liter bags in horses instead of dogs. We have a 1-liter bag. This is a 5-liter bag. And if you listen in the background, you can almost hear the ventilator going shh, shh, and then they've got it hooked up to the ventilator. And then this, if you can see on this picture where I froze, you can see how big this padding is on the table. All of the surfaces on that table are padded because no surface of the horse is supposed to be touching like a flat, hard surface. It all needs to be padded.
That point. And then the surgery team, like that, while we're doing that, the surgery team will prepare the horse for surgery, do any clipping of hair, prepping.
And so you can do a pulse oximeter. They put, usually this is like some type of block so that their teeth don't damage the tube, so they don't bite down on the tube. So we usually put something in their mouth to keep it open. And if I go back, you can see the ventilator.
That the surgery team will prepare the horse
is
for
right
surgery,
there.
do any clipping of hair,
There's the
prepping of the
ventilator.
surgical site. And then we all roll into the surgery suite, perform the procedure, and then roll the horse out, disconnect it from our monitors and anesthesia machine, place in the recovery stall, and let the horse wake up. We've got a new recovery stall that is equipped with a walkway that we can look down over the top of the wall and watch the horse and be able to hear the horse as they're waking up. Much better visibility than we've had before. And we also have a new recovery flooring system that consists of an inflatable air pillow to cushion and protect the horse until.
Now, one thing that is also different with horses, I've told you, normally for a dog and a cat, you sit with them, you check their heart rate, you check their eyes. You can see with this horse, a lot of times when they're first waking up, is they keep it dark. They put like a towel and tuck it under their halter to keep it dark, which helps them wake up more smooth. Somebody's probably gone in. When you start to see the horse, like normally what they're going to do is they're going to try to like throw themselves up with their head. This is, like they said, this is inflatable. At Purdue, this was like a flat mat or like a padded mat. But this, they can inflate with air. And then obviously they want to deflate it when the horse is getting ready to stand.
Ready to stand, to hopefully greatly reduce any risk of injury to the horse during the recovery process. So as we watch the horse wake up, we are primarily looking at their eyes and watching for twitchiness in the eyes, or what we call nystagmus, where their eyes roll back and forth from one side.
So did you just see that? Did you see how the horse is like, hopefully everyone's still there and saw that. That's nystagmus, and that I'm going to be talking about on recovery. That is what you don't, if a horse tries to stand while they have nystagmus, they follow their eyes. And you can see this horse, it's almost like they're Nystagmus, they're trying to find the horizon. They're trying to find a fixed point, but the problem is their eyes are going back and forth, back and forth. So you definitely don't want a horse trying to stand until the nystagmus goes away. And the ones that try to stand during that nystagmus are the ones that tend to flip and roll and have problems. So right now this horse is being good and is kind of just laying there, sitting up-ish, and you can see that nystagmus.
Very quickly. As long as we see that, we don't know the horse is, although sort of awake, is probably not going to be able to stand well on their own at that point. And so we wait until a lot of that is resolved and gone away, and then pull the plug on the mattress and allow the horse to have a firm foundation to stand upon at that point in time. We've put a lot of thought into how we've designed this facility so that the horse can very quickly and easily be moved from the induction process to get him on the surgery table, wheeled into the surgery suite, perform surgery, then wheeled straight out into the recovery stall, making it easy for us to work on the horse and also make it good for the horse as they go through the anesthetic process from start to finish.
Okay, so are there any questions about that? I have another one we'll watch tomorrow, but let me get back tonight. So basically, I mean, it was easier just to show you kind of like, okay, so from the time that the horse is, you know, we have to pre-med them, and then you want to rinse out their mouths. The other thing that we do, they didn't show in the video, is we typically pick out their hooves. So we bring them in the stall, and I think you guys would maybe have to do that when you go out to the farm. But you want to get any debris, and if their hooves were really dirty, we had a big brush and a bucket. We could scrub their feet, but usually their feet are going to be wrapped. Sometimes we just wrap them with vet wrap to keep them covered. Sometimes we took the surgical booties that you put on your head. Sometimes we put surgical booties and wrap them around their hoofs because, you know, their hooves are going to be hanging out in surgery. We don't want to drop any debris like into the surgical field or drag, you know, so you clean them out. You know, they're not sterile. We're just going to clean them out as best as we can. So pick out their hooves, wrap their feet, wash their mouth, and then bring them into the induction room. And this thing that says tilt table, in the video, some clinics, the wall is actually a table. We do this in cattle. I show it when we do cattle. But the wall, they can be strapped to the wall, and then the wall flips on its side and is the table. What they did in the video and what we had at Purdue was like a squeeze wall. It was like that gate, and you put the horse between the wall, and you have people push, because we don't want the horse to fall and flip in like the middle of an open room. We kind of want to do it in a protected area. And actually, might be able to, I know I keep flipping back and forth. There's actually, let's see. I'll try and show this really quick because this is kind of the opposite. This is a horse castration in the field, and you can see the difference.
You can tell this is really crispy, juicy, and tender because we wouldn't take the time to butter all these potato buns if it wasn't worth it.
Well, now I'm hungry.
McDonald's new crispy chicken sandwich.
But this is going to be field anesthesia. This is an example of field anesthesia. So this is the opposite.
Archer is a rescued Arabian stallion who's dangerous to handle. These horses, they got governed by hormones only if they are full stallions. You cannot turn your back up. Oh, it's okay. It's okay. Dr. Bull has to sedate Archer to handle him safely. What did you get?
Self-support. Lady rescue. He ended up just in the wrong hands with a bunch of other stallions, low man on the totem pole. Well, if he never backed out, he won.
Kareem wants to castrate Archer so he becomes more docile.
So he's had some
They
sedatives.
put me on a hard, dry spot. The very first year that I came here, 30-some years ago, there had not been a veterinarian for many years that castrated horses. And I remember in that summer I castrated probably 60 horses. Another shot knocks him out for the procedure.
I don't know if you can tell right now, you know, that horse was very wired. And now look at the horse. He's kind of a little bit wider stance, but look, the head is down, the eyes are drooped, the ears are a little back. So that sedative has kicked in. This isn't how he would be standing if he was completely awake and healthy. And now he's giving him the induction, which is probably like ketamine. He probably gave xylazine in the trailer.
When
And
I give the second shot and the horse will lay down, I tell people to get out of the way. We have no idea which way they fall. Okay, everybody watch out, step aside. But the horse falls sideways. And that's why I am in front. I'm hanging on to him. And tell people, stand behind me. It's the best. That's the same. You don't want to sleep.
Yeah. Calm as this horse has always been.
Very good. How long have you had him?
I've had Archer for a week. They didn't have any money to castrate the horse, and he just needs it.
What's the saying? Take the balls out so the brains come back? Yeah, there's a lady here. Yes, you take the balls out, the brains come back. And it is true.
Oh, God.
so it's a similar technique to cats where you go through the scrotum instead of doing a pre-scrotal incision.
Before it could take you aback. I cut through the skin both times. I get the testicles out, and then I cut out the skin in between. Oops, it's good.
Oh, disgusting.
Mhm.
Yeah. And that'll just heal us on its own?
All this. A horse like this, one day rest, with these little sores, he doesn't fight too hard. So, what?
So, you know, when you're monitoring a horse like this in the field, again, he's doing it very quick. You might have a pulse oximeter. You might try to feel the pulse. But the key is, like he said, everybody gets out of the way when the horse falls. You don't have them up against a wall so they can fall either way. You try to help guide their head so that they fall a little more gentle. There's not a smooth way to do it unless you're against a wall and people can hold the horse like against something. And the key is, how do we know this horse is almost ready to wake up? Well, there's going to be more blinking, maybe some head movement. Horses use their head and neck to get up. They throw their head and neck. So what you'll start to see is they lift their head. They're going to kind of start to do that. They're going to maybe start to paddle their limbs. And then that's going to be how you know the horse is almost ready to get up. And you have to just watch respiration. But whenever you're around a sedated horse, just always pay attention that they're going to act out because you don't want to get kicked. You know, if they start throwing a limb, you don't, usually stay away from the limbs and try to be very careful.
And break them and make a horse out.
So you see how they use the head to,
There you go.
and then you just try to balance them.
Let them get it by themselves, but they have their feet underneath them. They can fall, they can hurt themselves. When they get up, they're ready to get up and they walk away. Okay, you think you can walk?
I don't know. Look at the ones that are there. Like, okay, where's my feet? What happened? Easy, buddy.
I told Corinne after the castration, she'll see a big change in Archer. He'll be much easier to deal with, and he'll be a good riding horse.
Oh, I want to go home. He'll change his head because the hormones are gone.
Okay, so you get the idea, and that's just an example of what field anesthesia would look like versus, it being induction in a very nice big hospital. And again, in a field, you don't usually have a team of people. You know, there may be just a few of you. But, you know, you can watch respiration. You can look at their color, you know, their eyes. Don't roll down as much as dogs and cats do. So the eyes are a little bit unpredictable. And that's what we'll talk about tomorrow. I'll talk about how things are a little bit different. Do you have any questions?